It's my great pleasure to introduce Gary. We've all seen his career history in the email, so I won't stress it. But I think that it is very interesting exposure to commercial development and being right at the front end of really developing drugs, and then has come back to Australia and still keeping a strong interest in real drug development, but now also pursuing a sort of more academic career. And I found a very interesting tidbit that he got to know Thies while he was working in Basel. So there's a lot of Swiss connections in the WEHI, as you know, and there's another one. All right, thank you very much.
All right. So we'll kick off, and I'm going to stay after the presentation as well to discuss with anyone who's interested. So the theme for today is this disease group called Chronic Obstructive Pulmonary Diseases. And if you ask the general population, there's almost no awareness of this disease. So I had this experience recently last week going to a conference in Heathrow, and the immigration officer asked me, "What are you doing?" "I'm going to a conference on COPD. "What's COPD?" he said. And it's quite remarkable that this is the case, because if you look at the statistics on what we die from as a global population, COPD is the number 3 cause of death in the whole world. So it is a major international health problem. And if you look at the kinetics of where the disease is going, in contrast to all other chronic diseases, the death rate for COPD continues to rise. So for young people in the audience, if you're thinking about a good career, here's one. I can tell you the forward epidemiology for COPD is appalling. There will soon be about 100 million people affected internationally, and this is a tremendous health problem that is much under-recognised. So when I started off my career in research, I thought in the future there's no point doing any work on COPD, because in the future we'll have cleaner air and people will realise they shouldn't smoke. And this is exactly the opposite of what's happened in the whole world. The air's got dirtier and more people are smoking. So the epidemiology is wonderful for future researchers. I can recommend it to you. You and your children will be fully employed. So the term is what's called an umbrella term. COPD covers 3 related conditions: emphysema, which is the destruction of the soft lung tissue; bronchiolitis, which affects the small air tubes that conduct air into the lungs; and chronic bronchitis, which is the overproduction of mucus. And these are present in all patients with COPD to variable degrees. So if you think about COPD in the standard picture, you'd be thinking about people like this. It's actually like cancer. It mostly affects older people, and they've mostly been smokers, which is one of the reasons why the disease is under-researched, because there's this strange moral bias. So why should we do research on people who've hurt themselves by smoking in the past? And of course, that's not a logic that we apply to road traffic accidents. Why should we ever treat a young person who has a car accident? Because that's self-inflicted. Why should we treat most cancer, which is related to lifestyle choices like being in the sun and eating bad diet? Why should we do anything to do with diabetes? That's strictly to do with your diet in a large fraction. So it's a strange disease that has a moral overtone. But this picture is actually not very accurate, because if you look at the modern burden of COPD, this is the stereotypical burden of COPD: old people who used to smoke. And they're looking forlorn here because they're remembering all the wonderful parties they went to in the 1940s. The modern pattern has really changed. So in the whole world, more than 15% of people who have COPD now have never smoked once in their life, ever. So it's becoming increasingly prevalent disease in non-smokers, and it's increasingly affecting young people. So I put 2 glamorous young people there on the left-hand side, who you may recognise, the late Amy Winehouse and Emma Turlington, who were both, or one is affected and one was affected by COPD. And then on the right, the opposite of those glamorous young women, which are very poor women in poor countries who get COPD because they prepare domestic meals and are exposed to smoke when they cook. And so a lot of COPD affects very, very poor people, particularly women, and it's becoming increasingly a women's health issue on a global basis. Now, when we talk about COPD, it's important to understand how the lung functions, and the way lung function is measured with graphs like this. So if you took someone like me, clearly aged 35, as you can tell from how I appear, about 2 metres tall and very athletic, that's how and I did this procedure, which is to breathe in deeply and breathe out. You could measure my peak flow, which is a good and simple index of lung function. And you can see that we're engineered so that at age 20 here, our lung function continues to grow, and then we decline. And our lungs are very nicely engineered that we should be able to live to about 140 with normal aging before we would all die from COPD because our lungs fade away with aging. So these are a very important thing here, just how we measure lung function. Now, the next 2 slides are the dullest and actually the most important slides of the whole presentation. So we were discussing this before. You're doing medical research now. I think we'd all like to think that the money that's spent on medical research ends up in a useful treatment for people and improves things. If you ask the question, how is it actually that your research ends up being a useful treatment, it's because your work will be eventually put into a clinical trial. Okay? So the clinical trial endpoints for any of the diseases we work on are critically important for basic scientists to understand. And I've had to put one thing down as my number 1 lesson from life. It is to understand clinical trial endpoints and make sure you understand them from the point of how your basic research relates to clinical trials. So COPD used to be classified in this way very simply by measuring that procedure, the FEV1, how much air you can blow out in 1 second. It's a really simple way of measuring lung function. You can imagine if your lungs are damaged, instead of doing this, blowing out rapidly, you'd be doing this, much slower. So by measuring lung function, you can classify COPD into 4 groups here around how much air you get out in 1 second. And that was what was called the Global Obstructive Lung Disease Classification System. The problem with it is that when you put drugs into clinical trial and hope that they will improve the FEV1, to date, there has never been one drug found that affects the degree or the progression of change in FEV1, which declines over time. So what happened was people started to add in other endpoints, looking at patients' symptoms, such as breathlessness here, and global symptoms, and what happens during exacerbations and aggregate scores. And we now have this system, which is a very messy one, but very, very important. So this is the new classification system for COPD, and what it's trying to do, people hate it, but is to aggregate risk, future risk. Now, this is really important if you're thinking about, I'm doing an experiment in a mouse, how will that translate into clinical practice? So I've pulled out the key terms that are now part of this descriptor. There are 4 quadrants here, an index around breathlessness here, an index around how your symptoms are, and an index around lung function. So we've got this idea of people being at risk, having symptoms, being breathless, and having impairment, which all of these tools measure here, and lung function still incorporated. And now we also have this new term of exacerbation rate, which is the periodic worsenings that happen in COPD, mostly due to infection. So these are the reason this has happened is because you can't, with current technology, improve the FEV1. We'd have no way to do that. But these things are sensitive to some of the drug interventions that have been discovered. And so that's actually really important. If you're doing basic research, you want to understand how would my molecular intervention relate to a clinical trial outcome, because if there's no alignment between what you do and what can be measured in the clinic, your work will never be translated, ever. And we know from research in COPD and other lung diseases that from the time a scientist makes a discovery through to the first implementation, so only about 14% of discoveries ever end up being implemented as a treatment, and the latency time, the median, is 17 years. So by understanding these types of kinetics, you can try and improve the chance that your work goes forward. Now, of all the chronic diseases, COPD is really unusual. If you ask someone with cancer, what would you like from your treatment outcome, they will most often say, I don't want to die from cancer. That would be their main goal, to live longer. If you ask a COPD patient, what would you like from your treatment goal, because I've discovered something in my WEHI lab that will make you live an extra 10 years longer, they won't thank you for it, because COPD patients in surveys do not ask to live longer with their disease. And the reason's really interesting. We can get some clues here. First, from art. So this is the inner circle of hell, where the condemned have been condemned to suffocate for eternity. This is the horrible things that Americans do to people, to waterboard them, to make them suffocate. And this is what happens into your brain when you're breathless. And if you look at the neural pathways that relate breathlessness to pain, they're actually the same. So the sensation of breathlessness strongly activates anxiety, fear, and intense aversion. So people who have breathlessness do not ask to live longer because they don't want to live longer with breathlessness. They'd rather actually die. And all they want to do is to have relief from their current symptoms of breathlessness. That is their overriding concern. So they won't thank you if you find a life-prolonging therapy that doesn't relieve symptoms. And this, again, is very important to understand if we're to make better medicines for the future. So I'm assuming no one knows even where the lungs are. You might know where the lymph nodes, they're here in the chest. And if you inject resin into them, as has been done here, you can decorate the airways, which are here, this extensive network. And here we've got the arteries and the veins also shown up. And this is a human lung cast. I'm going to focus in a bit of detail at the small airways here for a very good reason. So my dream is that one day Drew Berry will do a beautiful lung animation, but he hasn't done that yet. And I think his life will be perfect when he's done one. So we have to make do with these other renderings. This is a small bronchus or bronchiole, right at the end of the branching network. And this is the alveolar unit here where gas exchanged, very, very thin membrane, arteries and veins. The red is smooth muscle. That's right down to the end here. The yellow's nerves. So there's beautiful structure here. This is a healthy lung tissue. And if we look under electron micrograph, the membranes in the alveoli are tremendously thin. They're at the limit of thinness to allow rapid gas exchange because, of course, the main job of the lung is to pick up oxygen and drop off carbon dioxide. And you need very thin membranes to do that. And because they're thin, they are very easy to damage. There's very little tissue there overall. And if we look in a bit more detail, this is healthy lung under the electron micrograph. I put that same diagram here for orientation. This is what one of these conceptual bronchioles looks like in real life. That's it there. And the consistency of that little bit of tissue is like wet Glad wrap. You ever had those plastic wraps and it's got wet and how it sticks together? So the only reason small airways stay open is because they are connected to these alveolar units here. And if you look along the walls of the airway, which we don't see in this diagram, all the alveoli attach to these very small airways all the way through the lung. And that's actually very, very important for understanding lung function, because those connections are full of elastin. And elastin, which you can see, I'm very youthful, you can see my skin here. You can do this to yourself now and do this every 5 years. Pinch the back of your hand and see if the skin snaps back, because as you get older and your elastin breaks down, this is a sign that you are aging. So luckily, yes, it's okay, not too bad, all right? The elastin is the recoil that allows air to escape from the lungs. And it's incredibly important because it tethers to the small airways here, which have no intrinsic structure. You can feel your windpipe here and feel the cartilage, the thick bands that keep the main air tube open. There's none of that in the deep lung. It's all done by these elastic connections here, which hold these small airways open. And so if we go deeply into the lung and start to think about what are the fundamental problems that give someone COPD, this problem of breathlessness and resistance, and look at the structure. So here we're looking at actual visualization of human airways. This work was done in Melbourne in the 1960s. People were asked to inhale a safe radio contrast media, and the airways were X-rayed here. And we're looking at the deep structure here. So what you see is that as you go deeper into the lung, the diameter of the airways gets smaller. And then we get to this critical point here, which is deep in the soft lung tissue where the bronchioles are located. And then if you ask the question, what is the cross-sectional area, you can see it goes up tremendously. So from this point where you've got the very small airways, the cross-sectional area of all airways increases tremendously, and that determines the resistance, because that cross-sectional area is where the resistance to breathing occurs. So any change in these small airways here has a profound effect on the ability to breathe air in and out of the lung, because it's the main site physically where resistance is located. This is the structural basis for the disease. And we'll see that small airway is one of the main targets for COPD. So again, if you're doing your research work, what you want to achieve is remediation of the changes in these small airways. That is the central goal of current research in the disease. So if we look at the components of our COPD, the emphysema, which is here, I've taken a human lung. This is obviously a post-mortem lung, and you can see there are regions here where the lung tissue's been destroyed and relatively normal regions here. We can see the destruction and the preservation of the units, and notice how there's loss of alveolar tissue and loss of these connections here. There's a bronchiole extensively tethered to the parenchyma, and this has been lost in this structure here. Now, most research projects in the field are trying to halt the progression of emphysema. People come into the clinic, they feel very breathless, and there's a treatment that's been made to limit the further progression of emphysema. You need to think this through. By that stage, someone is already very breathless and symptomatic. And what happens if you made a molecule today that completely halted progression of emphysema, patients wouldn't feel any better. They might not feel worse in the future, but they won't feel any improvement from that treatment because of the structural changes that are already making them breathless. And this has been one of the big issues in the disease. Treatments that could halt progression wouldn't produce any benefit. Really interesting problem. If we go into the bronchioles, so the bronchiolitis, you can see it's basically an inflammatory process, and we'll dissect this in a little bit here. A lot of macrophages, a lot of neutrophils, a lot of lymphocytes causing inflammation of the airways. There's a bit of smooth muscle here around the airways, so that will contract, and you can use bronchodilators to open it up a little bit, get a bit of relief. But the main issue conceptually for research is that if you try and block the inflammation, every available strategy that's been tried to date has done that, but worsened host defence. So people get chest infections, and chest infections can kill you in COPD. This is the main issue. How do we inhibit inflammation without increasing the risk of a chest infection? That's one of the main big issues in the disease. Okay, and then bronchitis, which is the overproduction of mucus. We can see that here. This is a healthy tissue, a small mucus gland. In COPD, these proliferate to a huge extent, so there's a very large number of mucus glands producing mucus which blocks the airways, and this is the disease stage here, and this is how much of the airway is blocked in humans. Progressive blocking with mucus is a very important part of the airflow limitation. So one strategy would be, if we could just block the mucus production, that could be very useful because you would remove some of the obstruction to the airways. And this is a very good area for research. So mucus is not trivial and much under-researched. So now we think about how this works physiologically. What we can all do now, for the fun of it, is to give ourselves COPD for a few minutes. So the way you do this is really simple. Because the elastic fibres break in COPD, the problem in the disease is not like asthma where it's hard to get air in. The problem in COPD is getting air out of the lungs. So when you breathe in, you expand your chest, and this puts a radial force outwards on the small airways through those elastic connections, and that tends to hold them open. When you reverse the cycle and try and breathe out in COPD, the airways collapse, and it holds the gas in. So if you want to, for a few moments, feel what it's like to have COPD, you just do this. You start breathing, just very gently, and each time you breathe in, you breathe out a little bit less, so you accumulate air in your lungs, and keep on doing that until you get very high lung volumes, okay? And then try and breathe with as much air in your lung as possible. Try and breathe in without breathing out. Fully expanded lungs, fully inflated, so do that, just do it to feel what it's like, and then try and breathe in without breathing out. So that is literally the problem the COPD patient has has, they gasp for air, trying to get air into the lungs, but they can't get it out because the airways collapse. And you'll often see them do this, like I'm doing now. They'll stand like this and purse their lips, so they create a back pressure, trying to open the airways. And we can understand these pressure relationships by putting the elastin fibres in contrast, put a false background in there, health on the left. And this is what's happening when people are trying to breathe out normally. So when you breathe out at rest, or if you're coughing or trying to force air out and you're healthy, the elastic fibres mean that you can generate tremendous forces on the lungs. When you cough, you have tremendous compression, and those small airways don't collapse. They're always held open, allowing the air to come out. In COPD, it's the opposite. The elastic fibres are gone, the airways collapse down. There is structural change caused by the bronchiolitis, making the airways thickened, and there's mucus in them. So all of these things make gas trap in the lungs. And it's an extremely unpleasant situation to have full lungs, be gasping for breath and not be able to get any air into the lungs. I mean, if you try and do it, you won't be able to sustain doing that for more than 2 minutes. It's really difficult. You'll just voluntarily, so I can't do it anymore. But people live like that all of their lives, and that's why they don't want to live longer, because it's such a horrible feeling the whole time. So our job as scientists is to think about, what are we going to do about it? How are we going to improve the situation for these patients? This is a very famous diagram. It's conceptual. It's the Fletcher and Peto diagram based on one of the first population studies of lung function over time. And it tells you some really interesting things. So this is conceptual. There's actual data which is a little bit different to it, but it's good enough to give you the idea. So we're starting off here, age 25, with normal lung function. Unless you've had parents who smoke, then you start off down here. Bear that in mind. Or if you've had bad nutrition from poor country, you start off down here. And then over time, your lung ages normally. So that will go on. And if you're a smoker, but not genetically susceptible, or if you're exposed to biomass fuel and not susceptible, you'll be fine. You'll keep on going, and you can live to about age 140 before you get impaired lung function. When you lose about half of your lung function, then you start to have symptoms. And these symptoms are being a little bit breathless, having a bit of coughing and things like this. People often ignore them, and things progress to the point where they become severely breathless, and they go to the doctor, and at that stage it's hopeless. So people who are susceptible and smoke get rapid decline in lung function because of the damage to the tissue. If they stop, that normalises, and if they stop late, it also normalises, but they may still be very, very disabled down here. So I have an uncle with advanced emphysema. He sensibly stopped smoking here. He's now in his 80s, and he's about there. That's just how it goes. Really sad situation. If we look at our current medicines, this is what's available at the moment. So I've made some of these with dear colleagues. Bronchodilators, which open up the airway smooth muscle a little bit. They're great in asthma. They work really well. In COPD, they work a little bit to help a little bit of gas get out. They're very imperfect. A lot of steroids are used, but they work poorly and increase the risk of pneumonia. Xanthines are hopeless. Antibiotics such as macrolides are used to treat infection in the lung and perhaps sort of their anti-inflammatory properties, but they cause deafness and they increase the risk of a heart attack. Antioxidants would be very good, but they're not very effective. If you vaccinate people to try and prevent their infections from occurring, COPD impairs immunity and vaccinations don't work well. Rehabilitation, which is physiotherapy, is very effective actually. And then there's some dramatic interventions such as cutting away lung tissue to remove the hyperinflation, which makes people feel better but kills them earlier. Giving them oxygen, which works in lung failure to some small extent, or transplant. And most experimental medicines are anti-inflammatories, anti-proteases and antioxidants, which is interesting to know. So if we think about the nature of COPD, it should be really easy to model it in animals because we know at least one of the main causes, which is cigarette smoke. So we should be able to do that. It's been known for a long time that the disease is genetically complex. So when you do GWAS studies or inheritance studies, you don't find major loci, you find many, many small effects across the genome, and this means the disease is genetically complex, so there's no single answer to it. The structural problems that I've told you about are the main problem. Now, just this year, there's been a big policy shift in the COPD world. It used to be said, well, it's impossible to use anti-inflammatories to inhibit progression because people have these structural changes, and by the time they come to the clinic, it's too late. And now people are saying, wait a minute, let's go back to this. Well, this is really straightforward. What about if we treat it here when people are pre-symptomatic and to prevent the progression? There's been a big change, the idea of coming in earlier. So there's been a revision of this. We don't know how we'd do it, but the idea of coming in earlier. But what is happening in the meantime, before we have effective early interventions, is that actually the comorbid conditions of the disease turn out to be the place where you can bring most benefit to patients. So these are the other conditions they have that track with COPD. And COPD patients have a lot of problems. Chest infection is the main one, but also their muscles get very weak, which limits their activity and makes them fall over because they lose their balance and don't have strong muscles and then die from a fracture. They have a very large amount of heart disease and circulation disease, and they develop cancer very often. So these areas here are the ones that people have focused on to try and bring immediate benefits to patients in the shorter term before we have ways of inhibiting the progression of the disease. I'll just go through these in the next little while. So a very simple model of the disease. You're exposed to an irritant, which would be smoke from biomass fuel or pollution or from a cigarette, irritates tissue, inflammatory mediators, accumulation of neutrophils and macrophages and lymphocytes in particular that produce oxidants, inflammatory cytokines, proteases which destroy lung tissue, and growth factors which make airways grow. And so this helps us to explain why we get mucus hypertrophy, fibrosis in the area of the small airways here because of growth factor overproduction, but also destruction of the tissue just nearby. You can have destruction and growth at the same time because of imbalance of proteolysis, apoptosis and growth of tissues. And these are the three hallmark diseases components here. If you take a mouse, expose them to smoke, just like people, some mice are resistant, some are very susceptible to disease. And if you take a susceptible strain, what you find is exactly like in humans, a progressive accumulation of macrophages which become activated and destructive, and they release proteases that destroy lung tissue. And a lot of neutrophils come into the lung here, and you get overproduction of mucus, and you can adjust the dose of cigarettes here in this particular case to make sure the levels of carboxyhemoglobin are just like you get in humans to make sure this is relevant. So this type of model has been used a lot. And I want to tell you about a little bit of work that we've been doing. Thies Ernst is here, so we've done some fantastic work with Thies and his crew. Toby's up the back. I can see Toby hiding up the back there. And also I want to talk about some work done with Margaret Hibbs. So the myelomonocytic cells, the macrophages and neutrophils, are very important for inflammation. And over years we've been working on what are the control mechanisms that regulate those cells. One of the things that we're focused on have been the SARC family kinases, because the SARC family kinases sit poised between inhibitory pathways and activating pathways. So do them conceptually here. We've got an activation process and an inhibitory process, SARC family kinase here, and an outcome that could be either an activation or an inhibition. And because the structures of these are known, it's possible to introduce point mutations to inactivate the kinases, to make them constitutively active, and to constrain their expression to certain cell types to work out mechanisms. It's been a very, very productive line of research. So in work done with Margaret Hibbs, who was at the Ludwig Institute, is now at Monash University at the Alfred Hospital. For some years we've worked on the Lin family kinases. These are overexpressed particularly in macrophages and B cells. And if you activate Lin kinase, you get a very interesting phenotype. So when this was first observed, the technicians rang up and said, the mice have got rice bubble lungs, because as you can see here, the extent of the emphysema was so obvious that bubbles called bullae were obvious to the naked eye at the margin of the lung. You can actually see the emphysema with the naked eye in these animals because it's so aggressive. And what's interesting is that the problem here is due to a macrophage development defect. Macrophages are very prominent in human COPD, and they release proteases that destroy lung tissue and growth factors that cause fibrosis, so they're a major target. The overaggressive macrophages produced in this disease destroy the lung tissue, but what's very interesting is as the animals age, the chronic inflammation that's present triggers a forward risk of developing adenocarcinoma. So adenocarcinoma lung cancer is very, very common in COPD patients. And you think, well, that's just due to cigarette smoking. No, it's much more than that. If you've got lung function problems and you've been a smoker, you've got 6 times more risk of developing cancer than someone who's smoked the same amount of cigarettes but doesn't have lung function impairment. And this suggests that there are strong linked mechanisms for the development of emphysema, COPD and lung cancer, which I'll come back to. So these mice spontaneously develop adenocarcinoma, and they've got a major defect in macrophage lineages, which causes the MACs to accumulate and destroy lung tissue. This is work that was done with Tees some years ago. We met as postdocs. I had hair at that time. Tees still has hair. And we met in Switzerland and sort of been friends ever since. So with Tees and his crew, we've been looking at the HCK kinase for really quite a long time. And we observed years ago, actually, a phenotype that was strikingly like what's now called ACOS, asthma COPD overlap syndrome, where you've got some aspects of very severe asthma and some aspects of very severe emphysema. These are mice that have an overexuberant activation of the innate immune system, so the inflammatory cells are driven to be very aggressive towards lung tissue. They also develop structural changes in mucus hypersecretion, and these mice too are susceptible to adenocarcinoma as they age. So inflammation again linked to the cancer risk. And of course, because they're mice, and because they're mice that live in WEHI, you can do all of these wonderful things to them, which is to knock in, knock out, turn about, transfer, and recombine everything at the molecular and cellular level. And so over the years, we've been working out, what would the intervention strategy be here? And we've tried all sorts of things. Steroids don't work, killing T cells don't work, blocking important cytokines don't work, but we've recently found some interesting innovations that we think could be important therapies down the track. So if you take these mouse models and look at the things that they're producing and say, are they actually relevant to human disease? Well, HCK is, because HCK is now a replicated human COPD risk gene. But if you look at the inflammatory molecules that these animals produce and ask, do they resemble what you find in humans? They're actually strikingly similar. This is a lovely diagram from a guy called Alvar Augusti, who's a Spaniard, really smart guy, and does very clear ways of explaining data. So he asked the question, there's a non-smoker, there's someone who's smoked but didn't get COPD, and actually large numbers of them, and here's a very big set of COPD patients who've got aggressive disease. What are the biomarkers that are present in their blood that could reflect the disease process? And so you see, for example, important things like the interleukin-6 pathway being strongly activated here, and fibrinogen, which is a cardiovascular risk factor caused by damage to the microvessels. So if you track these into animals, you find exactly the same signals. The interleukin-6 pathway is very, very strongly activated in disease. I won't talk to you about the work we've been doing with GP130 intervention strategies, but this is a major disease-driving axis here. And similarly, if you do the genomics, take all of the GWAS studies, all of the array studies, and from a human and mouse world, and put them bioinformatically together and ask, are they concordant or discordant? What you find is the following. So if you ask it on an individual gene basis, you don't find too many genes in the mouse and the human that are exactly concordant. There are some major genes that are, and these are important disease targets. If you ask about pathways, you get greater concordance, but if you ask about the function of those pathways, you get tremendous concordance. And I think this again is a general lesson for discovery. We need to be cautious going from human to mouse, mouse to human at the individual gene level, but these animal models reveal the dominant pathways are the ones that we have to pull apart to get better therapeutic interventions. So what we do in the lab is work with diagrams like this that imagine the whole of life for COPD patient and for a COPD mouse. So this is the unhappy day when the mouse arrives at the laboratory here, and this is when the patient or the COPD mouse dies. And this is continual exposure to a driving irritant. So there are a number of critical events that occur in the disease process. And again, if you're thinking about how would I use my science to bring a benefit? It's these critical intervention points that are the ones to think about, and how would I block that or improve that? So very, very early on in exposure to the irritant on the right genetic background, you get degradation of the matrix. So those little elastin fibres are degraded by neutrophil elastase and macrophage metalloelastase, and the fragments of elastin are actually very chemotactic. They work as chemokines in their own right to produce further inflammation. So one of the first things that happens is a self-sustaining loop where the proteolytic degradation of tissue drives further inflammation. That could be a good intervention point. The next thing that happens is that there's tremendous oxidative stress in the tissue. And the oxidative stress works in a number of ways, but particularly to cause post-translational modification of key matrix proteins and key signalling proteins, altering the properties of the lung tissue, probably in a semi-permanent way. And this contributes to a cycle of destructive proteolysis and also enhanced apoptosis, which begins to kill and destroy lung tissue, and it starts to erode away. Now, very, very early on in the disease, defensive immunity, which should protect us from chest infections, becomes impaired. So these disease processes here also impair immunity, and what happens is, I call it uncoupling. Destructive inflammation remains, but it's not effective in providing host defense against bacteria or viruses. And so chest infection becomes more and more frequent. And this is probably one of the major things that we could do. Could we find a way to recouple host defense so that we could minimize the burden of chest infections? Eventually, the macrophages become defective because of these modifications here and lose the ability to phagocytose and defend against infectious agents, but also to clear away dead tissue. So then secondary necrosis happens, further driving tissue. And so we get this cycle of apoptosis, impaired clearance, and secondary necrosis, sustaining inflammation. And at this point here, if you stop smoking, your lung inflammation will improve slightly after 1 year. It will initially get worse, and then it will improve a little bit, but it never goes away. It's now irreversible because of these self-sustaining mechanisms. This molecular attrition leads to enhanced aging by attacking telomeres, and some people think that COPD is actually just an enhanced aging process of the lung, because if we live to 140, we'll all die from COPD. Our lungs will fade away in 140 years. The other important thing that happens is that the growth factors, the oxidants, and other drivers start to mutate the progenitor cells in the lung, and so we move into a proto-oncogenic state where mutations are accumulated, greatly enhancing cancer risk. So you can think, if you start to understand these frameworks, there are multiple intervention points where smart young people could put their brilliant brains to help people in the future. And so in the mouse, we can measure emphysema. It's easier to do in the mouse than human because you can use high-res CT. You can get beautiful images of the mouse now. And if you induce emphysema in the mouse, as we see here, using an elastase, which mimics the normal disease process, you put some elastase into the lung, you'll see the lung tissue starts to become less dense. And notice the size of the lung here. So these are in vivo. These are the lungs actually in the chest in vivo. And notice how as emphysema progresses, the lung becomes larger and hyperinflated. So exactly as happens in humans, as the elastic fibres are lost, this progressive gain in lung volume, and it'd be great if we had a breathlessness index. I'm trying to train the mice to fill in the MMRC breathlessness score with their paws. It'd be great if they could just go, I was feeling okay in level 2, but after your intervention, I'm actually feeling level 1. It's very hard to measure breathlessness in the mouse, but we would anticipate that this type of structural change here leads to a physical interaction. So emphysema has been the main focus of much research, and we now understand there are many more than one processes. If you go back to the 1960s, the theory of disease was neutrophil elastase degrades elastin, causing the change, and then macrophage metalloelastase was discovered, so it became neutrophil and macrophage elastase causing the disease. But we now know it's much more than that. So certainly you have the elastases here, but we've also learned about other things. So the first thing is that was much underestimated is how important your growing up is. Because if you have developmental problems, if you're born prematurely, if your parents smoke, if you have serious infections as a young person, you're set up for bad lung function for life. So early life events are very, very important and very important for future lung health policy. Things like the interaction between integrins and TGF-beta, which controls local inflammation, are critically important. And if you impair these types of integrins, you get spontaneous emphysema. Whoops, sorry. Go back here. But we've also learnt about things like how the microvessels are attacked by disease. So there's actually the vascular side, and how apoptosis, aging, and damage to proteins all contribute to emphysema. As the disease becomes established, and because of the chemical modification, autoantigens are developed, and then there's a further driving mechanism of autoimmunity layered on top of this. And so the key processes are oxidative stress, biotransformation of molecules here. These are the things that have been shown in humans to be important. Nicotine addiction genes, resolution, called catabasis, which I'll talk about, immunity, aging, and oncogenesis. All of these are the main things that have been proven in humans, and all of these have been replicated in mouse models. So really quite a useful way to go ahead. So if we think about the big picture of COPD, it's like this. We have COPD at the centre, and then all of these comorbid conditions here: cancer, recurrent infections, autoimmunity, cardiovascular and muscle problems, and this overlap problem with very severe asthma. And I'll just pick out a few of those and talk about them in the concluding part of the presentation, being mindful of the time. Okay, so big problem, chest infections. All current strategies to inhibit inflammation, which drives the disease, increase your chance of getting a serious lung infection that could kill you. What are we going to do about that? It's a really, really big macro problem. So this was published just a few days ago, a very important study which suggests that this isn't part of the late stage of disease. This happens really early on, as we found in the mouse. So this is a study in almost 40,000 people looking at population databases. And the question is there something that happens in the population that signals that COPD is on the way? It was diagnosed here at this point. That's the diagnosis day, and this is 20 years earlier. And what you can see here is that as people move towards COPD in a healthcare system where all these things are captured, they report more and more chest infections. So this is lower respiratory tract infection here. And chest x-rays are used when doctors suspect that that infection may be a pneumonia. So we can also infer that over time these become much more serious. More infections and more serious infections as you move towards the final diagnosis of COPD. So we've put a lot of effort into understanding infection risk. Turns out to be a very interesting story. In Melbourne, we have a big COPD cohort where we understand what causes these types of infections or exacerbations. They're viruses, bacteria, mixed viruses and bacteria, and that accounts for about more than 2/3, almost 3/4 of all the clinical problem here, viral and bacterial infections. And we've modelled this. So give a mouse some smoke and give them influenza, and this is what happens. Smoke impairs immunity, uncoupling it from host defence, but intensifies inflammation. So you get higher viral titers, but also worse inflammation, which is mostly neutrophils and macrophages. That's a combination of smoke and influenza. And what happens then is the memory T cells, the CD8 positive memory experienced T cells here, are retained in the lung tissue for a very long time because of the epitope change in the structural basis, the fabric of the lung, which makes these memory cells very sticky for the lung tissue. And then they're able to, instead of killing viruses, which they do poorly, rather they activate macrophages to destroy tissue and release growth factors. There's a very important disease axis here. And this is human data showing the high level of CD8 cells present in the lungs. A very important disease axis that's been identified. Smoke ruins the ability of macrophages to work properly. Macrophages should normally easily eat bacteria. That's how they were first discovered, as bacteria-eating cells. So if you take fluorescent bacteria, healthy macrophages eat them. They're inside the max here. Expose a macrophage to cigarette smoke, and they lose the ability to phagocytose. So we see here very fewer cells. treat them with an antioxidant, and this is partially restored. And the reason is because of chemical modification in the toll transduction system for the most part. The oxidant stress chemically modifies the intermediates between recognition and effector phase, reducing the ability of the cells to kill tissue. And this is also why macrophages can't clear dead tissue properly, because the recognition and clearance system is chemically modified by oxidative mechanisms. And this is actually much more widely spread than just in the macrophages. If we look at chemical modification of tissue, you find extensive evidence for oxidation adducts in the tissue, for S-nitrosylation products in the tissue, and carbonylation, which is an irreversible chemical change. So this means that long-term signalling pathways and tissue are completely altered by the disease process. One of the reasons why it's so hard to restore health to the damaged lung tissue. So we've been working a lot on how would you improve normal healing of the lung, which is impaired, catabasis or resolution. So this is work we're doing with Bruce Levy at Harvard, and this is Steve Bosnowski from my group. So, some years ago we found in the blood this biomarker called serum amyloid A, which spikes up when you have a chest infection and then goes down. Okay, so that was interesting. We were very suspicious on why its levels were so high. We found the reason was this protein, which is normally made in the liver, begins to be expressed in macrophages of the COPD diseased lung. And I'll link this into inflammation and resolution. So once this is made in lung tissue, it becomes very irritating to cells and drives inflammation. It also has a role in cancer, as it turns out. So macrophages begin to make it. They lay it down into the tissue and it stays there for a long time, and then it acts like a signalling molecule in the tissue to promote inflammation. And it does this by instructing gamma delta T cells to overproduce interleukin-17, so that as its levels go up, we get more destructive neutrophil elastase through this axis here. Very, very tight correlation in humans between this protein and severity of inflammation. But what's turned out to be absolutely striking about the molecule is, as well as being a pro-inflammatory and inflammation-driving molecule, it fundamentally blocks one of the main healing mechanisms in the lung. So when you have an infection of any type, your epithelial surfaces and your leukocytes help to defend against the bacteria or the virus, but then they also engineer the resolution of inflammation, and they do that in part by cooperating in the transfer of arachidonic acid through two pathways, the 5-LO pathway and the 15-LO pathway. So stuff made here gets biotransformed here to produce beneficial molecules called lipoxins. And these work through what's called a promiscuous GPCR, G-protein coupled receptor, called ALOX. Now this is a very interesting receptor because it's able to exist in two states. It has one conformation which inhibits inflammation, which is a very beneficial state, but it can be pushed into another conformation which is intensely pro-inflammatory. So in the literature, it's been discovered twice as a beneficial healing receptor and as a strongly pro-inflammatory receptor. Same receptor, two conformations. What we've found with the guys at Harvard is that serum amyloid A protein, which we find is produced abundantly in the tissue and which drives chronic inflammation, fundamentally blocks the ability of lungs to heal because it binds on the side of the receptor there, pushing it into the conformation that is always pro-inflammatory and never beneficial. So it allosterically modifies the main healing mechanism, locking the tissue into a pro-inflammatory state. And of course, now what we're working on is making blockers of SAA and molecular derivatives of lipoxin like this one here, which are activators of this pathway, trying to restore normal healing back to the lung tissue, which I think is an interesting strategy. How are we going for time? Given the chance, I'll talk for hours. So what I'll do very briefly is just to mention that muscles waste in COPD. This is what happens as you get worse disease, your muscle wastes away. Part of that is because people become breathless, don't want to exercise, and then you decondition so the muscle goes. But a lot of it's inflammatory drive. Now, it turns out this is one of the main reasons that gives people problems. It limits their day-to-day activity, but also makes them unstable on their feet so they can fall over, particularly after a chest infection when the muscle gets particularly weak. And then in COPD, A small rib fracture, which affects breathing because of the pain, means most people will die from pneumonia if that happens to them. So very, very serious things if your muscles get weak and you fall over and crack a bone. What happens, you get a chest infection, you go to hospital, stuck in a bed, you get high-dose steroids, and you end up with a very weak muscle. So I'll race through this. You can model this in mice. Mice lose muscle, particularly during smoking and infections. Their muscles get weak, and we've got little mouse strength machines that we use where you can measure that. And the most interesting thing is that someone who's had a chest infection gets a spike in muscle wasting genes and muscle growth repressing proteins. For example, things like myostatin, which spikes up here. This is a clinical biopsy underway in a patient with COPD exacerbation. That's my leg there as the control. Doesn't hurt at all. Okay. And so these things increase. And we think it'd be possible in the future to improve patients' condition by blocking muscle wasting, interestingly enough, because that will help to prevent falls and then detriment. The last thing I want to make is just a simple point that COPD is very closely related to lung cancer risk, which is the #1 cause of cancer death in the world. And I was very happy when I went into the new building and I saw on the glass panel there, lung cancer is now. So the word lung appears in WEHI at least once, which is great. Terrible. The prognosis is grim. The incidence versus the death is about the same. When you've got incidence equaling death, it means treatments don't work. It's a wonderful thing. It's like superannuation for scientists. People who smoke now are investing in your future because 20 years later, they'll be getting lung cancer with an almost predictable latency here. And treatments are hopeless. These are Kaplan-Meier survival curves for small lung cancer, small non-small cell and small cell lung cancer. Treatments are very, very ineffective. So if you've got COPD, you're 6 times more likely to get cancer than pack year matched people. This means the processes are linked. And what we'll do is just make this point here. So if you do the sensible thing, for example, stop smoking, your risk falls off, but even after 40 years, and even if you smoked just a little bit, which is there, your lifetime risk never goes back to 0, okay? So do stop smoking if you smoke because you'll reduce your risk, but you never get back to 0. At this stage in medical lectures, you can see the medical students' faces draining of blood because they realise that they've done this to themselves. They've somatically mutated their epithelium. So this is a lovely study published a few years ago looking at gene profiles in people who are current smokers, those who stopped up to 30 years ago, and those who never smoked. And you can see here the gene profiles of a former smoker, even 30 years after smoking, more closely resemble a current smoker than an ex-smoker. Part of that's because of those persistence mechanisms, and part of it's because of mutation. And we know once you mutate a progenitor in the lung, a stem cell, you give rise to patches of mutated tissue, shown here with a genetic technique which reveals it by colour, so that the epithelium of long-term smokers is a mosaic of mutated tissue. And we know as well that these mutations, which have all been characterised in the context of lung cancer, cause the epithelium to release factors that can interact with other genes. So we measure, for example, how does the HCK locus, which is about 3% of all COPD, interact with the epithelium. These mutations here release soluble factors that interact with those mutations there, greatly increasing the risk of developing inflammation-driven cancer in the future. So in summary, not too much over time, it's a complex disease, not one solution, genetically complex, with multiple pathogenic pathways, increasingly affecting non-smoking people and increasingly women on a global basis. The structural changes are currently intractable. We don't have a way to repair those structural changes, and until we do, or we have early interventions, the comorbid diseases will be the ones where most treatment is directed towards. We're all hopeful that earlier intervention may prevent these structural changes, and we need to work out ways to do that without compromising immunity. Maybe developmental biology will be the way to go to preserve lung structure and to make new lung tissues through stem cell strategies. And I want to emphasise to you again and again, if you want your own work to go somewhere, so that when you reach my age, after 20 years from postdoc to now, it goes so quickly that time, if you want to think my research as a postdoc led to a useful intervention, I would strongly advise you to think about what would the translation pathway be. My research that I'm doing now, how would that actually be translated in a clinical trial? Because if we don't get alignment between the mouse model work and the model work and actual clinical interventions, your work goes nowhere. It just stays in the journals. It doesn't become a medicine or an intervention for people. So spend time on those, learning how the clinicians would in the future translate your work if you want your work to have major impact in the future. And that's a short summary of some current views on COPD.
We are only a bit behind time, so but Gary did say we'll stay afterwards to ask any questions that you're too shy to share with everyone.
But don't be shy, because...
Should we have that light down? Because whatever. So, are there any questions? Lynn.
I'm one of those Americans that torture people, but I think perhaps that comment could be toned down a little bit. But anyway, I was wondering whether tissues in the lung can regenerate, as the liver can, for instance.
Yeah, so many Americans are very good people, and I know Congress has reformed those terrible practices, so we're very happy to, but it does emphasise how horrible breathlessness is, and I think it's worth saying, not to criticise American colleagues who I dearly love, or America, which I more or less love. The lung in the adult has very little regeneration capacity. So if you have half a lung removed as an adult, there'll be compensatory growth in the contralateral lung, but adult human lung has very little ability to regenerate, and this is a major block for how we have regenerative medicine. The other really important issue is that the post-translational modifications and all the rubbish that accumulates in the matrix of lung tissue strongly suppresses differentiation programs of progenitors. So if you take emphysematous lung, pull the progenitors out, put them into culture, they're not too badly impaired. Put them back into a disease context and they just halt. So TGF-beta does that, other rubbish factors do that. And part of the problem for making a regenerative medicine strategy will be how do we clean up this poisoned field where we sow the seeds. It's really very, very difficult. So two major problems for regeneration, and the lung's not at all like liver.
Sorry, has anyone tried to inhibit elastase to treat COPD?
Yeah, so there've been a number of interventions tried. They've been and they've failed. So if you take people with advanced emphysema and give them a drug which covalently binds to neutrophil elastase, and you can prove that the elastase, neutrophil elastase, then that does not improve their current condition, it doesn't reduce their rate of exacerbations, and it doesn't seem to affect the rate of decline in lung function. So why is that the case? Well, neutrophils have three proteases, not just neutrophil elastase, and there's macrophage metalloelastase, but it's probably because at that stage already the lung is so profoundly impaired that even small benefits aren't registered as a symptomatic benefit by patients. And they've been very, very disappointing. Perhaps coming in much, much earlier in the disease with the same types of drugs could have a dramatically better outcome, but they've not been effective. Just a few weeks ago, a big trial with p38 MAP kinase anti-inflammatory inhibitors was presented, and they didn't do anything in terms of well-established disease. So reducing inflammation through that strategy just made chest infections worse. This is why all the thinking is going, these things don't work in late disease. So like rheumatology, don't use them late, come in very, very early. And the whole field is now thinking, how do we readjust our thinking to even measure the benefit very early on before people have advanced symptoms? But they've been very, very disappointing, the elastase inhibitors.
Just a last question.
Related to that, what is the agent in cigarette smoke that initiates the cascade? And does it naturally flush from the system?
Yeah, so cigarettes are an amalgam of rubbish. If you pull apart the components, it's not one thing. So it's not acrolein, it's not aldehyde, It's not 4-hydroxynonenal. It is to a large extent the oxidants in smoke, because smoke is intensely oxidizing. If you take smoke extract and use that fresh when the oxidants are vital, compared to when it's been aged and the oxidants have dissipated, there's profound differences in what that extract does, but it's not one thing. So if it were just one thing, probably we could have eliminated that from cigarettes and produced, God forbid, a safer cigarette, but it's not one thing. It's actually thousands of things in aggregate.
Because if it drained quickly, whatever that compound is, you could give that anti-inflammatory at the time of cigarette consumption.
Yeah, but this is highlighting a real issue. So this is one of the big issues in the field. It's like obesity research. It's exactly the same thing. How do we mitigate the cardiovascular consequences of bad diet or the pro-diabetic consequences of bad diet? Well, you'd use drugs to do that. And of course, it'd be better if people stopped eating, but they won't. So you give them medicines at the same time to try and reduce forward risk. We completely accept that idea. That's what's currently happening. Statins for heart attacks are exactly that. You don't modify your life, you take a statin instead. People just cannot accept that you could smoke and take a medicine to mitigate the risk of smoking. There's this moral imperative that says stop smoking, but all of the studies on smoking cessation show that it's very, very unlikely once you start smoking that you will actually stop. Very, very few people can do that. So there's a really interesting moral issue being played out now about could we have a medicine that inhibited the detriment of smoking, and what would that mean on the policy level in terms of smoking consumption, all the other risks. Really interesting discussion compared to other diseases. Yeah.
Right, I think we have used about time, so just wanted to